and there is trying to check now loculated enhancing fluid in the pelvis as well. The urinary bladder shows diffuse mural thickening. It is collapsed or empty, but it shows diffuse mural thickening with perivesical fat stranding as well, indicating urinary bladder abnormality. I want to check the sigmoid now. It's moving the other side. I'm sorry. So there is more concentric thickening of the sigmoid with also thickening of multiple small bowel loops and thick enhancing fluid collection in the pelvis with enhancing wall with involvement of the urinary bladder as well. But there are no intravesical air locules. Should I use this one and move?
Yeah, if you're comfortable, you can use that for scrolling.
Yeah, because it keeps going the other way. I'm sorry about that.
Yeah, no problem.
I'm just trying to get. Okay. So, disease progression makes me concerned about presence of a mass that has progressed further and maybe invaded the adjacent small bowel and the urinary bladder wall. Other possibility is the complicated diverticulitis further, but I think it should be like improving with antibiotics instead of and I can't see any intravesical air, so I don't think it's a fistula. It's maybe like infiltration by the tumor of the wall instead of a fistula. But still, maybe contrast study would resolve that. It would show if there is any communication or if the wall is reactive or.
Okay, so how would you like to proceed next?
I would inform the treating team, refer the patient to the gastroenterology surgery for maybe staging chest CT scan and check the bone window also. If this is patient might be also need colonoscopy and biopsy. Discussion after discussion of the case in an MDT, of course.
Okay, we'll go to the next case.
So this is a chest radiograph of a skeletally mature patient. There is loss of definition of left hemidiaphragm with a triangular-like retrocardiac opacity, concerning about left lower lobe collapse. I'm trying to check for any central opacity or cause. I can't see any central lesion or hilar lesion in the left lung, and the rest of the left upper lobe appears clear. On the right side, well, there is the right heart border seems to be straight, and the reps appear more horizontal steep. So I'm suspecting the patient might has a pectus excavatum. In my routine practice, I would check the patient's previous images and check if the patient is still in the department. I would examine him physically, and otherwise maybe check for lateral radiograph if available.
So, so what is your diagnosis again? Is it pectus excavatum?
Yes.
Okay, the patient has some acute pleuritic type of chest pain.
Sorry, pleuritic chest pain.
Pleuritic type of chest pain.
Okay, so check. Trying to scan the lungs. Well, I'm trying to find if there is any oligemia, but the breast shadow is covering part. Still, the border of the left hemidiaphragm makes me concerned about left lower lobe abnormality. That might be the cause of pleuritic chest pain if it is on the left side. Usually, pleuritic pain would be localized. Other than that, both lung apices are clear, the hilar shadow is normal, and both costophrenic angles are clear. So my primary concern is about left lower lobe collapse. I would like to take the case further by doing a chest CT scan.
You can see the images.
Okay, scroll from here. Okay, this is contrast enhanced chest CT scan, soft tissue window, axial cuts. This confirms left lower lobe collapse with air bronchogram. Trying to scroll through, check for clues. There is bilateral breast implants. And there's some cystic changes in the area. And I'm checking if there is any
Recording in progress.
No evidence of systemic arterial supply, and I didn't detect any endobronchial lesion, but I would like to check it on the lung window if available as well.
Yeah, you can look. Let me just put it here. Yeah, you can go to that.
Okay. So the trachea is patent, the left main bronchus is patent. So the bronchi are patent as well. No endobronchial obstructing lesion could be seen. So causes of lower lobe collapse in an adult might be related to mucus plugging or endobronchial lesion. Maybe follow-up checking with the patient previous images and follow-up. If it doesn't resolve, bronchoscopy would be recommended to rule out any occult endobronchial lesion. I would also like to check the patient's previous history. I think the breast implants were for cosmetic reasons, but I would check if there is any history of primary malignancy elsewhere.
Any differential diagnosis?
For the left lower lobe collapse, I'm thinking about mucus plugging and thing is that because my eye cystic areas, I want to check them in the cystic areas. Well, endobronchial lesions like endobronchial carcinoids, maybe, or endobronchial hematoma, also cancer, but I can't see any other features of malignancy in this image. Also can cause lower lobe collapse.
Okay. How do you take this further?
I would check patient's previous submissions and then follow up the patient. If this is due to mucus plugging, then it will just improve. But if it's otherwise, then the patient would need bronchoscopy to rule out endobronchial lesion.
Okay. We'll go to the next case now.